to you, Lakshman sir.
Yeah. Good evening, dear doctors. On behalf of Sun Pharma Solitary Division, I welcome Dr. N. Arun, consultant gastroenterologist, hepatologist, and interventional endoscopist, Apollo Hospital, Greaves Road, Chennai. Over to you, doctor.
Good evening. Good evening, all the delegates of being here. And I would like to thank Sun Pharma Solitary Division who gave me an opportunity to be here in this wonderful evening to discuss on in one of the most complex entity in the field of gastroenterology. It's none other than irritable bowel syndrome. And to tackle on irritable bowel syndrome, it's a chronic entity. And most of the patient will be having multiple doctor shopping for a longer duration of time. So with a characteristic presentation of abdominal pain, along with varied stool patterns, most of the patient will be taking medications for a longer duration of time, which doesn't seem to have any major clinical response over a duration of time. But once a patient turns up, how are you going to approach a patient how are you going to recognize the patient that this characteristic phenomena comes in the background of functional bowel disorders, nothing that irritable bowel? How are you going to categorize? How are you going to recognize the presentation? And what is the basic approach you are going to tackle? And how are you going to investigate and how are you going to manage a patient with irritable bowel? And over a period of time, how are you going to follow the patient with irritable bowel? That's what is very important for the next 20 to 30 minutes of discussion in which we are going to proceed. As you all know, irritable bowel syndrome is one of the characteristics. It's usually, as per the Rome criteria, it comes in the guidance of your functional bowel disorder. It's a common GI condition in which there will be three characteristic presentation. You'll be having recurrent evidence of abdominal pain or discomfort for at least 1 day per week, which is going to last for at least 3 months, associated with two or more of the following. One will be a defecation pattern is going to get abnormal. That will be evidence of a change in stool frequency along with change in your form of stools. These three criteria should be fulfilled for at least a duration of 3 months with symptom onset at least for 6 months prior to the event. That's how you are going to diagnose a patient with irritable bowel syndrome. And when you're going to look into irritable bowel syndrome, the most important thing is in the diagnosis of your irritable bowel syndrome has been evolved over time from your own 3, round 4. And when you're going to look into the categorization, there are four major entities. One is based upon your IBS type C, IBS D, IBS mixed, and IBS unclassified. In the Indian scenario, how are you going to categorize? How are you going to recognize the etiological factors for irritable bowel? It's always a complex and it's very difficult to recognize. It's usually the clear-cut definition, the clear-cut entity has not been identified, the clear-cut etiological trigger. There are so many pathophysiological concepts, so many pathophysiological factors are being identified. Approximately 1/3 of the patient with irritable bowel syndrome may be having evidence of your colonic alteration, colonic gut motility, abnormalities, all those things will be there to categorize this patient with evidence of irritable bowel. And this is a functional disorder of a GI tract, as you know, and pathophysiology is not be well understood and doesn't occur due to functional or biochemical abnormalities. It occurs due to disorder intestinal motility, as what have been discussed before, and intestines remains hypersensitive to stimuli like food and stress, and usually the patient will be having well healthy. The patient sometimes will be having evidence of multiple comorbid disorders. The patient may tend to have evidence of obesity, thyroid, diabetic status in the background, or multiple other comorbid presentation, sedentary lifestyle, and usually the patient doesn't seem to, when you're going to do a endoscopic and colonoscopic evaluation, the patient doesn't seem to have any major abnormality, but always this kind of patients will be having worsening of presentation in your clinical approach. The patient will be anxious, the patient will be agitated, the patient cannot able to do the routine activities. Sometimes the patient will be in the restroom for a longer duration. Sometimes will be having a prolonged diarrheal presentation. Some patient will be having prolonged constipation-like events. These are all the various troublesome factors which will always disturbing a patient with irritable bowel syndrome. And it usually doesn't lead to evidence of any colitis or any cancerous changes, and apart from it is going to have a significant impairment to your quality of life, function status, mental stability. All those things is going to come down over a period of time. Once the patient is going to land up with evidence of irritable bowel, it's one of the very difficult entity, even for the best of gastroenterologists to tackle. So you need to recognize the presentation in a prompt way, rule out all possible etiological triggers, and look for the basic work of what is needed, and how are you going to counsel, how are you going to approach, how are you going to alleviate the anxiety, how are you going to alleviate the pain, how are you going to alter the consistency, whether the patient is having evidence of diarrhea, or whether the patient is having evidence of constipation. How are you going to approach? This is how you need to tackle a patient with irritable bowel syndrome is one of the characteristics entirely to present. If you're going to look into the current scenario of India, so the prevalence almost will be going for almost around 44.8% in the entire population, and the IBS-C will be in the range of almost around 0.3 to 0.5, and D will be in the range of around 1.5. Mixer component will be very characteristic, will be in the range of 1.7. And usually we cannot able to categorize certain patients in which we couldn't able to label this as IBS-C or D. The characteristic variation will be there, will be categorizing as IBS unclassified presentation. And as I discussed, the commonest clinical features, always you need to look for the precipitating factors, and you should remember three major pathophysiological concepts before checking on with the clinical features. I'll be telling you three things. One is your altered GI motility. So what is going to happen once your GI motility, if it is going to get altered, the myoelectric activity of your gut is going to get altered. That will be predisposing to multiple wave frequencies, low wave frequency, alteration in your spike potentials. All those things is going to take in your gut, which will be predisposing to your irritable bowel, number one. And number two will be your visceral hyperalgesia, will be the second preponderant factors. You need to look into that, because there will be a potential underlying mechanisms of the desensitization of afferent nociceptive path, which is going to have a predominant involvement in the characterization of your irritable bowel. And third will be your psychopathological concepts will be having a major take on, because once the patient is going to get affected, if your mind is active, your gut will be active. If your gut is active, your mind will be active. That's why it's also called as gut and brain dysfunction. So this is how once the patient is going to have evidence of dysbiosis, the gut and brain dysfunction is going to get take on. At that point, the patient will be having worsening of irritable bowel to proceed. So always you need to control the various events like your neuropathological disorders like your depression, your anxiety, your panic attack, your hypochondriasis. All these things should be promptly addressed if you want to tackle this irritable bowel syndrome in an effective way. So as we all discussed, the commonest, how are you going to have a proper history? History taking is very, 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 very important. So how are you going to recognize once a patient, as I already told you, the Rome 4 criteria, you're going to look into that. And always look for evidence of alarming problems. What are the alarming problems before taking on with this clinical picture? So alarming problems, usually you should not miss whether this patient landing up with evidence of irritable bowel or any inflammatory pathology or any malignant changes. So always look for alarming presentation. Alarming problem point number one will be if the patient tends to be in the older age, don't simply label the patient as irritable bowel. If the patient age, if it is going to be more than 55, you need to be very, very cautious. That's number one. Number two, if it is acute even, if it is acutely progressive, then you need to be very cautious, more of nocturnal symptoms. If the patient passing stools frequently in the nighttime, even after sleep, which is continuously disturbing the patient routine, then you need to be very cautious. If the patient is having any other pain symptoms, like your other secondary focus of your abdominal pain, like your pancreatitis, other focus, or if the patient is having any persistent hemodynamic instability, like your fever, tachycardia, other worsening presentation, you need to be cautious. Or if the patient is going to land up with evidence of anorexia, loss of appetite, so you need to be very cautious. Or if the patient is having significant anemia, if the patient hemoglobin tends to be in the lower range, then you need to be very cautious. And if the patient has persistent diarrhea, which is a painless diarrhea, then you need to be very cautious. We should not miss out any evidence of spurious pathology like your malignant change in the colon, apart from that, if the patient is having any bleeding manifestations, if the patient is having rectal bleed or pain, it's very characteristic. You should not miss, apart from if the patient is having any hepatobiliary complications like your jaundice and your lymphadenopathy changes like your lymphomatous presentation, and if the patient is having malabsorptive states like your steatorrhea and other complications. These are all the alarming factors. And any family history, if the patient is having evidence of gluten intolerance like your celiac pathology, all these pointers we need to see. And that's how you need to recognize a clinical presentation to diagnose a patient with irritable bowel. Simply coming to the OP, if the patient walking into the casual, your OP practice just like that, and if you're going to label a patient just like that as irritable bowel, most of the time we'll be landing up in no man's land. So always a thorough history assessment, head to foot assessment, all these pointers is very important to clinch the diagnosis of irritable bowel syndrome. Apart from that, clinical picture, very simple. As I already discussed, your abdominal pain will be very characteristic, and the patient will be having a change in frequency and change in consistency, and sometimes the patient will be having mucus, the bloat, and sense of urgency, which means the rectal involvement, rectal urgency to defecate. The diarrheal presentation may be there once the patient is going to land up with evidence of irritable. As per the various guidelines, if the patient is having evidence of persistent diarrhea, you need to rule out any pointers of infection like your giardia, your cryptosporidium, and apart from your Clostridium difficile, any antibiotic diarrheas. All these pointers you should not miss when you're going to walk up a patient. And apart from that, you should remember there are certain other etiological triggers, like always as per the ACG guidelines, when you're going to look out all the possible triggers, even for the gallbladder pathology, sometimes may mimic, and if your gallbladder dysfunction, if it is there, that might be mimicking your EIBS. All this history taking proper assessment matters a lot to diagnose a patient with irritable bowel syndrome. And that's what we need to take on. So this is how, what is the reason for pain pathway? That's very interesting when you're going to look at the muscle contraction. As I already discussed, altered visceral motility is very, very characteristic. So what is going to happen? The calcium, the main mechanism which is going to get acted on, that's how the mechanism of antimuscarinic, the muscarinic agents along with your cholinergic agents is going to get a prime mechanism of a treatment target when you're going to address a patient with irritable bowel. So what's going to happen? And so once the nerve is going to get stimulated, the abdominal wall, the nerve excitation, if it is going to get take on, there might be evidence of your calcium from your sarcoplasmic reticulum, it is of your muscular layer, which is going to release your calcium. And once the calcium is going to get released, what's going to happen? It's going to bind with your troponin at your TNC troponin C site. Apart from, once it's going to get bind with your troponin C, and what's going to happen? There will be a conformational change which uncovers the myosin binding sites of your actin, and which will be predisposing to your, once a myosin get interacts with your actin, there will be evidence of your muscular contraction to get checked on. And what is the mechanism for this acetylcholine? See, if you're going to see, so any action potential, if it is going to get triggered in your neuromuscular junction, the acetylcholine is going to get released, and followed by it's going to stimulate your sodium channel. Once the sodium channels get opened up, that will be releasing of various action potential pathways along the T tubules, which will be having a strong impact in your calcium calcium absorption. So what is going to get happen? The tropomyosin binding sites is going to get activated. That's how the muscular contraction is going to get take on. And once the calcium is going to get released, the relaxation process, if it is going to not get in prompt way, that's how the muscular contraction is going to get take on with this mechanism, for to whom the pain pathway is going to get augmented by in the background of irritable bowel syndrome. And this is what the basic definition for your IBS-C. Always irritable bowel syndrome constipation will be having a differential presentation with your functional constipation, in which most of the time the patient doesn't seem to show any evidence of abdominal pain. In the background of IBS-C, you need to be very characteristic. The clinical features will be, your straining will be very characteristic for more than 25% of the population, and passage of hard stools for more than 25% of time, and feeling of incomplete evacuation for more than 25% of time, and 2 or less stools per week, that's very characteristic, and 2 or more of the symptoms, if it is going to last for more than 3 months of duration, then you're going to consider this patient as IBS-C. That's how you're going to define it. And there are so many revised guidelines I've been checking on, but this basic definition we should not forget. And how are you going to recognize a patient? So diet should be, once a patient is going to address a patient in the background of constipation, huge list of molecules are there, starting from your bulk forming agents, your laxatives and other things. Main thing is take care of your diet. The diet low in fiber always will be having a predisposing factor. And apart from that, you need to look for evidence of FODMAP pattern, which means fructooligosaccharides, your disaccharide, as well as your polyols, all these pathways to be addressed, and your sedentary lifestyle. You need to do good exercising, control anxiety, unwanted medications like anticholinergics, anti-Parkinson's medicines, and your medications for your neurological, like lithium, other things. Apart from that, if the patient is having very elderly presentation, you need to be very, very cautious that the patient may land up with evidence of constipation. And diarrhea, as I discussed, more than 3 stools per day, more of watery loose. Muscular cramps will be a characteristic presentation with bloat and nausea and abdominal pain. And if it is going to last for more than 3 weeks, which means the chronicity, the patient of IBS type D, And you need to stop the diarrhea with your anti-motility drugs and antibiotics like your rifaximin and other things you're going to take on. And apart from, once you're going to diagnose this, as per already discussed, with evidence of irritable bowel, in which the defecation pattern along with frequency and consistency, if it is going to get altered for a duration of at least 3 months, and symptom onset at least for a period of 6 months prior to diagnosis, you need to be very cautious. And once you're going to label, you need to be very cautious. You need to take on 3 major mechanisms. One is by dietary alteration. So fatty foods, junk, fried foods, alcohol, smoking, excess fiber, all these things to be addressed properly. And as I discussed, the low FODMAP diet, if the patient is having evidence of diarrheal presentation, you need to be very cautious. And psychosocial therapy, cognitive and pharmacological therapy is so important. And always we need to address the anxiety and alleviate stress. And pharmacotherapy, need to target the specific etiological triggers, specific clinical presentation like your abdominal pain or constipation or diarrhea. So always we are not supposed to forget the huge list of differential diagnosis for before tackling a patient. If you're going to see a patient with IBS-D, you should not forget the huge list of differential diagnoses like your lactose intolerance or any caffeine uptake, caffeine abnormalities, or any alcohol intake-related events, or apart from that, any IBD-like presentation, or if your patient is going to have any evidence of malignant changes, or if the patient is having evidence of celiac disease or any colorectal pathology or thyroid metabolic complications. These are all the things which we need to consider as a differential diagnosis. These are all the things we need to keep in mind if we are going to walk up a patient with IBS. That's all we should not forget. And whoever is going to have predominant constipation, you should not forget whether the patient is having neurological abnormalities like your Parkinsonism or multiple sclerosis or diabetes or metabolic complication. The secondary causes for your constipation, you list of secondary causes like your metabolic, your drug-induced abnormalities, your neurological pathology, all these things, your spinal pathology, all these complications to be addressed as secondary causes of constipation. You need to rule out all the possible pointers to label this patient as IBS Chat C. That's all. So prognosis usually depends upon the clinical presentation. Usually will be recurrent symptoms of varying severity, but life expectancy in individuals with IBS is comparable with the general population. It's always been comparable with the general population. We should not forget that. And apart from that, so once you're going to take on with the pharmacotherapy, before going to evidence of pharmacotherapy, you need to identify, is there any complications for a patient with evidence of irritable bowel? So once a patient is going to land up with evidence of chronic constipation, what are the things you should not forget? The patient may have evidence of anal fissure or hemorrhoidal changes, or if the patient is having persistent diarrhea, the patient may have, again, hemorrhoids or bleed, or if the patient is having poor quality of life or stress-related pathology, or the poor dietary intake. What is going to happen because of the psychosocial abnormalities? The patient may have nutrition deficiency. All these pointers you need to address before tackling a patient with irritable bowel, and the complications need to be assessed, properly segregated, and to manage in an effective way to control this irritable bowel syndrome. That's how it's a multidisciplinary approach. Just like that, putting a patient on medication doesn't mean that the patient is going to respond soon. So counsel, identify, rule out the possible triggers, and think about the duration of therapy, what kind of treatment, what is the predominant problem, assess the comorbid presentation, and counsel the patient effectively to tackle the comorbid presentation, tackle the patient with effective molecules. That's how you're going to improve the patient with irritable bowel. And to take on with the main area of discussion of your pharmacotherapy, so always the goals will be, you need to alleviate the pain. Colonic motility alteration is going to get significantly improved, and we need to take on with your diarrheal as well as your constipation in the management protocols. So spasmolytics for reduction of spasm as well as pain, your laxatives and antidiarrheals depends upon the clinical presentation. And once a patient is going to treat, if the patient is going to have evidence of abdominal pain or bloating, so you need to be very cautious when you're going to use your musculotrophic antispasmodic or your anticholinergics. Antimuscarinics can be considered. And this is all the list of molecules are there. Briefly, I would like to address all these things will be having 3 major mechanisms. One is muscarinic pathway, calcium mobility, along with the sodium alteration. So what is the major mechanism of action of your mebiverin? That's the major entirety to be considered. It is going to have a strong, direct, smooth muscle relaxant. That's how it will be a predominantly musculotrophic. And when you're going to use your mebiverin or drotaverin, so what's going to happen? It is going to inhibit your sodium influx. So what is going to happen? It is going to prevent the excess influx of your calcium, in which the contraction process, if it is going to get activated, it is going to have strong inhibitory potential, and that's how will lead to inhibition of your duodenal as well as your colonic contraction. And this is how basic mechanism of action of maybe willing to take on. Apart from that, your calcium channel blockers, your anticholinergics and anticholinergics, you need to be remember about the various huge list of adverse events are there. For example, your blood vision, your taste alteration, dryness, all these complications you need to get addressed. So safely, we can go for your maybe very direct smooth muscle relaxant rather than considering with multiple other medications. And CCBs to some extent along with your anticholinergic, for example, your hydronium bromide can be considered. That the mechanism is going to inhibit your muscarinic receptors, and which the coupling of your calcium and acetylcholine, which is going to get augmented, and followed by the calcium mobilization is going to get augmented at the colonic epithelium. That's how it's going to block the calcium transport through the calcium channels in intestine smooth muscle cells. That's how the mechanism of action of your CCBs, like your along with your anticholinergics like your hydronium bromide. Apart from our primary consideration when you're going to use your maybe valine. So the mainly by sodium influx and potassium and calcium influx is going to get prevented. That's how you're going to have a strong potential response with your maybe valine. And for example, addressing the other events like your constipation, you can use diet counseling, as I told you, the fiber diet along with laxatives, bulking agents, your dietary fiber. So they may decrease the gut transit time, decrease intracolonic pressure, which may reduce the pain. Apart from prokinetics, may be useful in dominant irritable bowel, constipation predominant. Antidiarrheal, you need to be very cautious, like when the patients have diarrhea, like, but you need to rule out any evidence of secondary complications like your obstruction, other pathology. You should be very cautious. If the patient is having evidence of obstructive events, we need to be cautious when you're going to use your antidiarrheal drugs. Psychotropics definitely will be playing a major role, like your amitriptyline and other pathways, tryptamine and other molecules. All these things can be considered, but antidepressants will be having SSRIs, will be having a potential benefit. Your TCAs will be having a potential benefit when you're going to have a pain predominant irritable bowel. Your anxiolytics, for example, starting from your benzodiazepine antagonist, will be having a potential role. For example, your chlorodiazepoxide, when you're going to consider, will be having a role along with a combination of maybe to tackle a patient with irritable bowel. And as I discussed, the basic mechanism of action was the key molecule, but you're going to see right now your mebivarin, which is mainly a musculotrophic antispasmodic. It's directly going to act on your gut muscles at cellular level. So what is going to happen? It's going to block your sodium channels in the muscle cell, and it's prevent the excessive influx of calcium. Once the influx of calcium, it's going to prevent the efflux, is going to get ready. Apart from your muscular spasm, the contraction is going to get relieved, and followed by the muscle spasm is going to be improved. That's how it's going to relieve the muscle spasm. As I already discussed, unique spasmolytic activity by your mebivarin. It is going to inhibit the sodium influx through the sodium channels in gut muscles. And as I discussed, it prevents excess influx of calcium, and it's going to relieve your muscular spasm. So mebivarin can be having a strong potential role when you're going to tackle a patient with irritable bowel syndrome. And the pharmacokinetics, very safely, you can use rice daily for the patient. Mostly it be absorbing after rapid and completely absorbed, predominantly in the duodenum. And distribution will be having no significant accumulation after multiple doses. Metabolism is mainly by your esterase mechanism. Once it's going to get formed into esterases, that might be having evidence of your mebivarin and other things, acid and alcohol to get released. Apart from the major metabolite will be your demethylated carboxylic acid for mebivarin, and DMAC, the half-life will be in the 2.4 hours. And usually the dose will be approximately thrice daily. 20 to 30 minutes of before food will be a predominant dosage to be considered. But mechanism is mainly by not excreted as such, but metabolites completely, and metabolites are excreted nearly completely, and veretric acid is being excreted into the urine, and mebivarin alcohol is also excreted in the urine, partly as corresponding carboxylic acid and partly as demethylated. This more of theoretical pound, no much of recommendation to remember that, but you should not forget certain things which will not have a major impact. Even if the patient is having significant cardiovascular, or if the patient having renal or other coexisting complication, mebivarin can be used safely even in elderly population, renal and hepatic impairment, or if the patient is having pediatric population. Pediatric, no major recommendation in children and adolescents below 18 years of age, but over the period Once a patient cross 18 years, so no major dose adjustment needed in elderly population. As I discussed, the major mechanism, it's not going to relieve the pain alone, but it's also going to regulate your gut motility. That's how the U-specific population is going to identify, and it's going to reduce the number of mass movements in the colon and reduce the sigmoid colonic motility in hyperactive patients, hyperactive subjects, and it's going to prevent the mass movements which is going to happen. And that's not going to just abolish the spasm and pain. It's normalize the gut contraction, as I already told, and it's going to have a significant effects in your high level of colonic activity. As I discussed, the normal peristalsis, if it's going to continue, the spasm is going to improve. And highly effective and superior to dicyclomine when you're going to use maybe in reducing the frequency and severity of abdominal pain. See, in this graph, if you're going to use your dicyclomine, the frequency and severity is not much of recommendations. And in case with your maybe wherein you can able to identify a significant reduction in your frequency as well as the severity once a patient is going to use for a duration of time. So the indications will be a predominant diarrhea or constipation in the background of spasm and pain. Always, you should not forget, rule out the secondary etiological triggers. And if the secondary etiological triggers, everything tends to be negative. And if you are labeling the patient as IBS, type C or D, at that point of juncture, it's advocated to use the patient with maybe variant. But you should be cautious always if the patient is having other cost, other comorbid presentation in the background of pregnancy, lactating women, or any other complications. If the patient has severe cardiovascular instability, all those indications you need to be cautious when you're going to use your maybe variant. Better to play in a safer way. Apart from that, other indications will be your chronic irritable colon, a spastic colon, a mucus colitis, and GI spasm secondary to any organic pathology like your regional enteritis and diverticulitis. As you all know, as per the criteria for diverticular, the patient will be a phenomenon of pain-related onset, and the patient will be a presentation like your IBS. So always you can use your maybe variant to tackle that kind of presentation. And contraindication usage in pregnancy, not major recommendations. And drug reactions usually allergic. Apart from rash, no major drug interactions been reported. And apart from that, anticholinergics, as I already discussed, it will be having major adverse events as you have a period of time, like your anticholinergic effects like your drowsiness, your blurring of vision, dry mouth, urinary retention, palpitations, your tone manifestations, hypotonia, all these things may be a characteristic presentation of your anticholinergics, like your bromide and other things when you're going to use. So always be careful when you're going to use your anticholinergics when compared to your antispasmodics. And main thing is your mebivarin acts directly on the gut muscles and not on the muscarinic receptors when compared to anticholinergics. And major adverse events, no major adverse events with your mebivarin, no serious interactions will be the drug interactions. And hypotonia will not be a major characteristic presentation like what's happening with the anticholinergics, since it's going to limit efflux of potassium ions. No major dosage adjustments needed in the elderly population. And when you're going to use a combination of your mebivarin with chlordiazepoxide in the background, see, chlordiazepoxide is a benzodiazepine substitute in which you're going to use that. It's going to have, because IBS will always a gut and brain syndrome, anxiety will be a characteristic presentation. So why? Because the microbiota alteration, the gut-brain axis, if it is going to get altered, the neuroendocrine immune pathways, if it is going to get disrupted due to stress-related discomfort, so all these things will be having a flaring up of event with your irritable bowel. And screening of IBS patients for evidence of anxiety as well as depression and treatment of those comorbidities in addition to treating of IBS symptoms could improve the patient outcomes significantly. And as I discussed, and prevalence of anxiety in IBS, when you're going to see your function GI disorders, including your various huge list of GI, starting from upper GI to lower GI, including your irritable bowel, associated with predominant psychosocial complications like anxiety, depression, your hypochondriasis, along with your panic attacks. All these problems to be significantly addressed, and Indian data tends to be sparse about prevalence of anxiety in irritable bowel. So meta-analysis of 7 studies showed patients with IBS from India are 8-fold greater risk of anxiety and FT5HT receptors and which will be predisposing to your anxiety. The serotonergic neurons release transmitters into the synapse where they activate the 5-hydroxytryptamine receptors on the postsynaptic neuron. So overactivation of these 5-hydroxytryptamine receptors, it's thought to be seriously associated with increased level of anxiety. That's all a major mechanism of anxiety in the pathway of IBS to be considered. And to come into the discussion about chlordiazepam as an add-on molecule when you're going to target with your irritable bowel, and it is going to alleviate the anxiety. So the spasmodic events is going to come down. It's a long-acting benzodiazepine. So following the administration of chlordiazepam, amount of the actual drug peaks and then drops. Apart from that, it is converted to an active metabolite, which altered to another active byproduct, which changed it another active metabolite, and until a more easy byproduct like oxazepam is going to get produced. So the prolonged duration effect considerably and makes long-acting benzodiazepines more effective in treating your chronic anxiety-like presentation. So they are preferred because they have less severe withdrawal symptoms because blood levels of the drug decline slowly over a period of time. So pharmacokinetics, the succession of active metabolites to oxazepam will be in a prolonged duration of time. That's how the long duration of action is going to get established. And they'll be having a predominant allosteric modulators of your GABA receptors, GABA A receptors. So allosteric modulation, it's going to have a ligand-like effect that binds to a site other than the primary site and changes how that site is going to get function. So what's going to happen? This means that the benzodiazepine do not directly activate the GABA receptors instead of GABA A receptor for the transmitter. This makes it easier for lower levels of GABA to activate the receptor. So once the lower level of GABA, because the GABA is the main inhibitor neurotransmitter in the brain and is responsible for the inhibition of your various other neurotransmitters like a glutamate, norepinephrine. Can you able to hear my voice?
There is a break in signal, so now it's okay.
Now you can able to see my screen or not?
Yeah, now we can see you, sir.
So my screen, sir?
Slide is not coming.
Slide is not coming.
Yes,
Just
sir.
a minute, please. Some issues. Okay, I think I'm about to complete. I'll be talking on that. What's the reason the slide is not coming, suddenly gone?
Sir, please go on Zoom tab again and share the screen again.
Can you able to see the slide now?
Yes, sir.
Can you able to see the slide now?
Yes, sir. It is in full screen also. You
Yeah.
can continue now.
So the dosage of your mebuvarin, if you're going to recommend at a duration of at a dose of around 135 milligram and your chlordiazepam at a rate of around 5 mg. So for tackling a patient with IBS, so what's going to happen? We'll be having a significant potential to reduce the spasm as well as your control of anxiety. Ideally, the recommendation will be 20 to 30 minutes of before food or 3 times of dose usually will be recommended, but you need to be very cautious when you're going to use your benzodiazepine-like presentation and when you're going to tackle a patient. But at night dosage, most of the time, the patient will be having a significant impact when you're going to use it in the management of a patient with irritable bowel syndrome. And it is going to have a significant decrease in abdominal pain, as well as it's going to improve the quality of life. The pill burden is going to get decreased, and the risk of medication non-compliance is going to get decreased. And apart from that, as I discussed, predominant dosage of 3 tablets, but be cautious when you're going to use at a rate of 3 tablets, but you can use at right time, predominantly will be having a significant potential response. After a period of several weeks, when the desired effect has been obtained, the dosage has to be reduced gradually. The route of administration will be predominant in the oral formulation, and duration, not major recommendation, but at least for a period of 2 to 3 months to be considered when you're going to use a patient in the management of patient with irritable bowel. Various clinical evidences to support the beneficial role of your mebuvarin as well as your chlordiazepam in IBS. So in this study, in this paper, 5 centers across India, a total of 60 patients been assessed for a duration of 8 weeks in which the endpoints. So for 8 weeks, approximately for 20 minutes before meal, they will use the patient. So the baseline day 1 followed by day 4, week 4 as well as week 8, they've been assessing, in which they have been able to label score. They can be able to identify the significant changes here in various parameters, the symptom severity scoring system of your IBS from week 4 to week 8 is having a significant impact. So decreases in mean scores from baseline at week 4 and week 8 was observed for each of the parameter with the IBS symptom severity scoring system. So this is how your number of days with abdominal pain, your severity of abdominal distension, your dissatisfaction of your bowel habits, and your quality of life, your abdominal pain, and other parts, all those things will be having a significant impact when you are going to use this molecule for a duration of time. Apart from that, so in this graph, if you can able to identify that at week 8, the anxiety will be having your significant potential response when you are going to use your maybe with your chlordiazepoxide combination, and majority of patients achieved a significant meaningful improvement of more than 10 points in IBS scoring at week of 8, and the quality of life is be having a significant impact, and the patient improvement will be in a greater way to consider this molecule over a period of time to tackle the patient with irritable bowel syndrome. And regarding the safety wise, in this study, no major adverse events been reported, few nausea, headaches being there. Apart from the no major events, at week 8, all 60 patients reported good tolerability as per FDC, and investigators also reported good tolerability in all 60 patients, and mild in severity, all events were mild in severity and resolved during the study without any major action being taken. So what are the vital findings from other clinical studies? So when you're going to use this molecule, there will be adequate relief of IBS pain and discomfort, and the bowel habits will be having significant impact. That improvement will be there, and the distension is going to have a bloatedness will be having a significant response. Almost 83% of the patient after 3 weeks of maybe were in treatment, and chlordiazepoxide, which is going to have a appreciable improvement of your anxiety. Around 40 to 50% of the population will be having a significant response. That's how we are going to combine this molecule will be having a new potential role. And the key takeaways before you are going to wind up, always irritable bowel syndrome is a diagnosis of exclusion. Rule out all the possible pointers. Look for the presentation. Don't simply jump to the conclusion that this patient is IBS. If a patient walks into the casualty or emergency, or if the patient landing up with evidence of in OP practice, don't simply label this patient as having only irritable bowel. Always assess the patient as a whole. Take a proper history, clinically assess, look for the possible complications, coexisting presentation, look for the comorbidities, assess the patient from 8 to 4, and look for any serious clinical manifestations like organomegaly, nodal encasement, anemia, pickle-like presentation, all these pointers. Look for red flags, as I already discussed, bleeding manifestation, older age, and severity of presentation, any mass we are going to identify, any uncommon etiological triggers, any uncommon problems. And if the patient is having any evidence of secondary causes like celiac, lactose, other evidence of constipation, other diarrhea, or secondary events of constipation, or secondary events of diarrhea, all these pointers you need to analyze before labeling this patient as irritable bowel. Once the patient is going to diagnose with irritable bowel, so categorize the patient, whether the patient falls in C or D or mixed or unclassified, categorize, and some patient will be mixed presentation. So usually mixed will be very complex because once you start the molecule, the patient may have diarrhea. Once you treat the diarrhea, the patient may have constipation. So mixed presentation. So alleviation of anxiety is very potential role to consider this patient. And always you need to use the antispasmodic with the anxiolytic molecules. And once you're going to have a significant impact, serial follow-up is needed. And don't jump into some patients with evidence of initial presentation of IBS. Later, the patient may have worsening of other GI manifestations. So always if the patient lands up with the same problem, doesn't mean that the patient is having evidence of irritable bowel syndrome all along. So you need to consider all the possible pointers, do proper workup, do the basic GI surveillance, depends upon the patient's clinical requirement, and proper blood profile, your endoscopic and colonoscopic surveillance if the patient having evidence of secondary potential causes. Rule out all the possible pointers and then assess the patient as a whole. That's how you're going to tackle the patient with irritable bowel. And with this, I'm happy to rest my presentation. Thanking you all for patient listening. And if there is any question, I'm happy to take on. Thank you very much. Is there any questions from your side, sir? Anyone is in the track?
Thank you, sir, for your wonderful
Yeah, yes, sir.
presentation.
Yeah. Thank you very much.
On behalf of Solitra division, I thank Dr. Arun for his wonderful presentation. Nice evening, Doctor. Thank you, sir. Thanks for your presentation. Yeah.
Thank you very much.
Thank you, sir. Bye.
Thank you, sir.
Thank you, sir.
Thank you, Ji.
So, sir, with your permission, can you conclude?
Yeah, you concluded.
Thank you.
Thank you. So, from here, I'm ending this session. Thank you.
Yes, thank you.